Evening, people. How you doing? 8 o'clock on a Tuesday evening, which means one thing. It's the Sports Therapy Association podcast, which is actually a live video cast. In case you're listening to the podcast, it is recorded live every Tuesday at 8 o'clock because we like it live. It's more spontaneous. We can put guests on the spot. We can have live questions. It's just kind of like, that's the way we roll. We do it live, the same as Run Chat Live. In case you're wondering who this voice is, it is Matt Phillips, creator of Run Chat Live. So if you do want to join us live, then just go to YouTube, the Sports Therapy Association YouTube channel, on a Tuesday at 8 o'clock, and you will see. You can even set a little reminder once it gets posted up there, and you'll be notified when we are live. So anyway, we've reached episode 107 now, which is basically 107 weeks since we started, every single week. And we're starting a new topic now because it's a new month. We're in July. June was all about a focus on business, and thanks again for people who've emailed in, and the conversations are still continuing. We had some fantastic guests all looking at the business side of running a clinic, and very much worth checking out. All those episodes. There's information on how to improve customer experience. There's information on how to, the 5 mistakes. We had Tim Allardyce commenting on the 5 typical mistakes, which I can just hear ching ching, said one of our guests, just sipping back on their Cinzano. I'm not going to say whether it's Nick Knight or Dr Emma Cowley, but one of them is just sipping back there, enjoying the good life. Got a big multidisciplinary clinic happening, and they're just there looking like Puff Daddy. It's beautiful to watch. We'll be bringing them up later on anyway. But yeah, so check out the Focus on Business. You can see it on YouTube. You can, if you want to watch the video, you can obviously listen to it on any podcast app. Let me just bring these up on full screen so you can see them. So yeah, YouTube, they're all there, all the episodes, 107. If you do go to our YouTube channel, then be sure to check out the Women in Sports Therapy podcast. There's actually 4 episodes now. Latest one, Dr. Claire Minshall, WIST as it's known for short. Amazing podcasts. You really should listen to them, whatever your gender. They're covering all aspects of women in sports therapy with Dr. Fiona Higgs and Deb Sterleroli. So do check them out. If you prefer to listen whilst you're running, for example, then podcast apps work. And you can also go along to the sta.co.uk, because I have added some nice links in there. If you go to the podcast section, and you can choose Spotify, Apple Podcasts, Google Podcasts, Pocket Casts, whatever you like, whatever's easiest for you. So July is here, and we have a focus on the foot and ankle. Brilliant idea. That's the next 6 months on the Sports Therapy podcast sorted. All I'm going to do is work the way up from foot to head. And I'm very excited to bring a couple of very experienced therapists as guests, Nick Knight and Dr. Emma Cowley, who know each other. I've got a funny feeling they do know each other, and they've met before. And they're going to be joining us very shortly to do an introduction on the foot and the ankle. As always, if you've got any questions, if you're joining us live, then if you fill out the comment, I can bring it up onto the screen. For example, if you're watching the video now, Nikki Mansfield, your message is now on the screen. It says, evening all, though I might miss the start of this, but our man Norrie, it's going to be a long one, people sit back. Our man Norrie smashed his quarterfinal with time to spare. Well done. Nice one, which is very nice of him. Congratulations, Nikki. I'm sure you're very proud of Norrie. Gary Benson, founder of the Sports Therapy Association podcast, is in the house as well, saying hi, everyone. Hope you're all well and looking forward to this chat. Becky Cowley's just gone, Nick! Exclamation mark. He's used to that. Spoiler alert. Interesting. Becky knows so much. And then Catherine Reimer is here as well. It's a great place to hang out, people. We've already got a couple of Sports Therapy Association regional reps here as well. So if you are a sports therapist or a sports massage therapist and you want to chat with people in your area, then again, try joining us live, 8 o'clock on a Tuesday night. Bam, there we go. Right, that's a reminder to switch my phone off. We don't need that anymore. So professional. Right, okay, I think without further ado then, we will start a month of focus on the foot. I shall bring up the guests. Hey, Nick Knight. Hey, Dr. Emma Cowley. How are you?
Good evening. All good.
I'm so excited. How's that for an anticlimax?
Be careful what you wish for.
We've already kind of discussed the whole thing, how it's going to flow so easily. So I'm very excited to have you on here. Thank you so much again for giving up your free time. This is why people, if you are listening to the podcast, they're lovely podcasts, aren't they? They're free. Don't forget the guests are giving up their time as well. Experts who have dedicated every single inch of their soul to their profession all of their lives. And here they are just giving an hour on a Tuesday night for us for free to help you, to benefit you and your practice. So if you are listening to the podcast, do please just leave a review, leave a rating, if it's going to be 5. And that helps our episode appear higher when people do a search. So if someone puts in the foot and ankle, bam, they will be able to listen to the great word of Dr. Emma Cowley and Nick Knight. So please do that now. Maybe pause the podcast and just do it and then come back. Right, so thanks again for coming along, you two. Podiatrists, I'm very excited because I know from being a sports, or from working my way up from massage therapist to sports therapist, that the foot has always been like I think it's the biggest reason to refer something out. It's like, okay, that looks weird. You're walking with a very strange gait. I'm not sure what the hell's going on there. Get out of my office and go to the podiatrist. Why is the foot such an area of mystery? Does it deserve to have that reputation, or what's the reason? Either of you?
I think it's because it's incredibly complex. So it's sort of like caught with the bones of the body in the lower limb and in the foot, and you're sort of thinking it's one of these sort of masterpieces of engineering, and yet actually as podiatrists we're still learning a hell of a lot about it. And it's one of those things, well, actually we spent 3 years training looking at the foot and the rest of the lower limb, and yeah, it is very, very complex, and it surprises me on a daily basis still.
Yeah, and I would add to that, it's a specialist part of the anatomy as well. It's unique to humans. There's no other part of the body that sits at right angles to the rest of the axial and the appendicular skeleton. So it's got some organized structures that are evolved specifically for bipedalism, for standing on 2 feet and running on 2 feet as well. So a lot of the structures you'll find in other animals, but they're called different things and they do different things. And so, yeah, it requires an understanding of load bearing and how those structures work moment by moment during a step, and that being very unique to how humans run as well.
Okay, you've already blown my mind, which I knew was going to happen within the first, because it's when you said they're specific to humans, I was like, I'm racking through my brain through as many animals and species I could think of. I'm going, shut about, how come, really? What are you referring to specifically with that?
Okay, 2 big ones. I'll give you 3 big easy ones. Okay, the first one is our hallux, the big toe.
Yeah.
In other primates, it's like a thumb. It's opposable. In humans, it's aligned to the other toes. So that is better it's in the direction of travel. So it's better for powering forwards. It's better for running rather than grasping. So that's the first difference. The second difference is that we have a big bulbous heel bone. So that is for landing on and for transmitting forces up into the kinetic chain. And the third difference is that we have an arch that sits away from the ground and acts as a leaf spring. And then so it can compress, and it brings adaptability, but also it has controlled stiffness, and that creates a stiff spring that can return energy when you're running. So you compress it and it recoils back and springs you forward. It gives you some free energy when you're running. That's just 3 of the differences.
That's enough. That's brilliant. And I'm actually feeling really guilty. And this is an example of how we focus so much, because it's the typical sports massage therapist or sports therapist sitting around the table. Oh, do you know what differentiates humans from the rest of animals, except for a few small monkeys? I'll give you a clue. And that's our kind of like, wow, using thumbs. It's amazing, because we can open things up and we go to stories about monkeys who can do it and stuff. And you know, but never thought about the big toe can't do that. And that's just as significant, if not more, the fact what it can't do. I don't know what came first, the stiff toe or the arch and the Windlass mechanism, on whether they came together.
Well, arguably, it depends when you speak to evolutionary biologists. Depends who you speak to, and it depends on the latest evidence as well. But it seems that we didn't come down from trees. It seems that we evolved alongside other hominids and pre-hominids that some of them were in trees, some of them were what we call obligate bipeds that stand up and don't crawl and walk on 4s. Some do it habitually, so they do a bit of each, and some of them are in the trees as obligate arboreal locomotors. Sorry.
It's going to be brilliant. People, just sit back. Pause it, make a cup of tea, because this is just going to be, get your pad out, Becky, if you haven't already. I can imagine Becky here comes like she's come 106 times at 107, and even now I can hear she just run to the kitchen to get her notepad and just going, oh, here we go again. I mean, that's a lovely segue, because
on the go.
in episode 3, the 3rd week, we are going to be talking to James Earl, and the topic's going to be evolution of the foot, which is one of his passions, and he's written books and stuff. So that's going to be very exciting. So that's a really nice segue to that, even though I really want it to continue now. We're going to have to wait. Because today, we're going to, again, I love that already, because it is pointing out most of our audience are sports therapists. and sports massage therapists. Do you get the impression, because you've both worked with different disciplines, obviously, even though you're podiatrists, do you get the impression that still the information given to a lot of other professions regarding the foot is limited or erroneous? Is there myths and misconceptions out there?
Go on,
Yeah.
Nick.
Yeah, I think there definitely is. And even still within the podiatry profession, there's still a lot of stuff that, should you say, haven't kept up with the times, I think is a nice way of with putting it. And so it's not just outside of podiatry, it happens still within podiatry. But that's the beauty of science, though, isn't it? It's constantly evolving. I remember I was looking through some of my notes from a few years ago, and then what I was telling patients, like, you might want to phone up and give them a refund and say, do you know what, was I really saying I'm really, really sorry? But at the time, that was the best I knew. But I think we've all just got to keep our mind open to change and challenge what we perceive to be correct, and just accept that we'll learn new things as we go along. So that's outside of podiatry as well as within podiatry as well.
And I would say, coming from a more sort of educational point of view, where, you know, I teach physios and OTs and nurses and all sorts of different disciplines, as well as having worked with them clinically and research with them. Yeah, we all come with our biases, and it very much depends on having worked with an individual. So my impression of sports therapists, I've worked with some phenomenal sports therapists, and you know, I've also worked with some, or come across some, that I've wondered if they're even come through the same route. But then I guess you guys have met podiatrists exactly the same, some that have blown your mind and some that you're like, have you even read recently? You know, so I would be really careful about judging a profession. And I speak to myself as I say this, because relationships are so important. And actually, when you ask a patient what they want, that's often very different as well. So I might be great for one patient, but really not great for another one. My skill set may resonate really well with one, but not with another. So my definition of good might be on the end of the patient rather than on my judgment, actually.
That's so interesting. And I think that's really useful for particularly sports therapists and sports massage therapists to hear, because there is a lot of information which sports therapists are having to kind of, they realize they've been taught, paid a few grand for, and it's being questioned now, sometimes quite violently on social media, which is the downfall of going online too much. But yeah, it's really healthy hearing from two professionals, as I was going to say as old as you, as experienced as you, who are still having to check what they, who are still having
receiving hairlines. It's not like...
I haven't got any old photos of you, don't worry, it's fine, no one will know. But yeah, it's really nice to hear that you're giving people permission, that it's okay to change. And I'm interested in what you said, Nick, there, because I think that's a fear that some soft tissue therapists listening, I've definitely received emails talking about it, where they worry about going back on what they said to a patient, maybe a patient they've seen for a year or something, who's coming in regularly, and they've got to kind of suddenly do something a little bit different, maybe introduce something they haven't done before, or a bit more of a chat about the psychosocial factors, whatever it is, or strength training. What tips have you got for getting over that fear of patients going, why are you changing your mind? That's ridiculous. Why all the money I've paid you for the last 6 months?
Because my tip is just do it. I have sometimes things haven't gone to plan, and I've reflected and reread my notes, and I've looked back and said, do you know what? I wasn't that good that day. So I just say to the patient, no, I'm really sorry that that wasn't me on my A game. I messed up. So now let's try and put it right. And actually, patients seem to respond to really well, just having that honesty of, okay, look, he's a human being, make mistakes from time to time, but now he's trying to correct that mistake. And yeah, I've had patients put a complaint in before, but then I've said that to them, and then they turn around and said, I'm going to give you 10 out of 10 because of how you dealt with it. And actually now everything is fine. We're all human beings. We can't get it right all of the time, but I'm always one to sort of own up. And when I say, look, or I turn around and say, this is the best of my knowledge. And as Emma said, I may not be the right person for you now, but I know someone who is. So I'll refer you over to that. I think we do need to try to get over this whole worrying about referring on or saying or admitting something. And when I've spoken to colleagues that have now gone more the medical legal route, a lot of the cases that are brought, it's just patients, it just comes down to a breakdown in communication. So actually these patients, if you get that communication right, then actually it doesn't tend to ever end up in litigation or things like. Patients are just grateful that you're there trying to help, trying to do your best. And they understand we're human beings all the time. And again, don't be afraid to challenge each other. If every time me and Emma fell out over every time we challenged each other, we wouldn't be friends. It's sort of like, it's almost, we've got colleagues like when we get together and we have a chat. So colleagues, I reckon, sit down and bring the popcorn out because we can sit there and have a right old discussion, but then have a drink afterwards. It's nothing personal. It's just trying to learn and be the best we can be.
Yeah, absolutely. And you know what, Matt, neither of our disciplines is a precise science. We'd love to think it is. We'd love to think we're evidence-based and we've got an answer for everything. And like in optometry, there's an acute, refractive index we can work with. It's just not the case. We're working with people. People are messy. We can't dose what we do. You can't dose an orthosis prescription. You can't dose a strengthening or a stretching plan. You can try, you can use a FitVP protocol, but the individual and how they respond to that, we just don't know. We've done some of the science. There's some work done at the University of Plymouth by a physiotherapist a few years ago who was trying to look at the dosage, if you like, of stretching in children with spasticity. And to start off with, they were looking at people without spasticity. And it was like trying to pin a jelly down, you just couldn't really determine what the effect was. But what we do generally know is something is better than nothing, and that it's a complex intervention. So building that theatre, that therapeutic rapport, that therapeutic alliance, that trust, the sharing of information, the targeting of questions to help understand goals, and then trying to understand the power of your therapies and the power of your assessment in order to select the right therapy as well. That is likely to lead you to the best outcome. But it's really important. I do this with patients as far as I can, is to try and determine at the outset what good looks like. So what do we want from this, and is that likely to happen? How up for this are you? You realize it's going to be hard work, and we'll go from that start point, really.
Yeah, as I say to patients, human beings, we are reliably unreliable.
Yeah,
but that's what makes all our jobs interesting, because we can see 10 cases of heel pain in a day, but everyone is different. They may have the same diagnosis, but everyone is still different. Frustrating at times, but it makes your life fun.
So this is it's first of all just lovely sitting back listening to you. So please don't stop because you feel you've been talking too long. You just keep going. We've got another 40 minutes, and I'm quite happy just to have you two talking. It's great. But we're saying something which I get the feeling, or as far as sports, let's go to sports massage, for example, none of this is being taught on courses. Therapists are still getting turned out with the impression that, well, I hate saying it, but if your shoulder hurts, what is it, uneven to the other one? Let's get them the same height. Symmetry is still the guide of test retest. And sure enough, when you touch something, do something to somebody, or tell them something, the clinical gold standard for a soft tissue therapist is often, if you measure them at the end and their pelvis is now level, then that's going to cure their back pain, or their legs are the same length. But that's what, look, if you listen to the podcast, they're both laughing. Okay, but that is, and I don't think I'm speaking out of turn here.
Oh,
but
if only life was that simple. Yeah, that's what I'm thinking.
That's what it is. So my question to you, once you stop your giggles, is, you're involved in education very much. Do you still see that on courses? Because you mentioned like sometimes podiatrists are still thinking that there is a blueprint, and you need to walk, move this certain way, and neutral subtalar and all of this. Is education getting better, or is it still stuck? And
I hope so. And you know what? I think the loop between clinic and education is improving through social media and other forums. But what I would say is I hate seeing the pendulum swing like it does. Things go in and out of fashion. Suddenly massage is everything. The next minute's nothing. Same with electrotherapies, the same with manual therapy, the same with orthoses, you name it. They all have their moment, and it's emperor's new clothes in the conversation almost every time. What I would say is nearly always the case in life is that there's a middle point. There's a case where perhaps there's a window of opportunity for massage to help create a window of opportunity for a therapeutic effect of another intervention. I rarely find monotherapies work in MSK conditions management. It's normally additional either consecutive or simultaneous use of therapies together, along with expectations talked about. I'm not going to say managed, but certainly set and discussed. And the conversation about pain, I know you've no doubt discussed pain. I think you've got either one just coming or you've just had one. I saw one advertised the other day. And the conversation about pain is huge in terms of outcomes as well. So all I would say is, it's great fun, isn't it? We all have a chat. We can all laugh. We can all giggle. I'm not laughing at any one. I'm laughing at the concepts that come and go, because they do it in all the professions. And if only life was that simple, and it often isn't.
Yeah, good old structuralism. But I mean, for example, because this was advertised as the anatomy of the foot, so we're going to stay on track here. Yes. We have talked about anatomy. We talked about the massive calcaneus and the unopposable hallux, and it's just great. But we're going to move back a bit to anatomy. So how are we going to do that? Let's talk about some movements of the foot, or the anatomy of the foot, which, if soft tissue therapists understood the anatomy a bit more, it would help them look after their clients. So what aspects of anatomy should we talk about?
I would say that probably starting with understanding anatomy, you have to take a sort of a funnel approach. And I would start with the gross anatomy, structural anatomy. Go to Gray's or whoever, whichever resource you want that helps you learn what's where, what groups they sit in, what joins onto what innervates what, and so on. But don't stay there. I mean, that is almost a recipe for disaster by staying at gross anatomy. You have to progress to function. And once you progress to function, it is, honestly, it's like the secret. It's like the magic in clinic. And I know, Nick, you've got a story about when you started looking and measuring 3D gait, didn't you? You kind of had your eyes opened.
It is. It's because we know that, unfortunately, it's not simple. So we know that actually most structural assessments and sort of a structural anatomy assessment, and then you try and correlate that to dynamic function, it just doesn't work. So if you see someone standing and they've got a pronated foot type, it doesn't mean anything really to when that foot is then moving. And yeah, I thought I had a good understanding of how human beings moved. Then about 6 years ago, I got a 3D gait system and actually realized I knew bugger all. And actually, I now say to my patients, they sort of say, oh, you see me doing this, how am I going to run? And I sort of said, I've been looking at 3D data for 6 years and I still can't find a way to predict what you're going to do. So I've just given up predicting, and what it will be. And I'm not going to guess, because the odds are I'm not going to get it right. So, and yeah, and you just realize how different people adapt to different things. And okay, it'll go outside of the foot, but you'll change someone's shoes, or you'll put orthosis, or you'll give them some gait re-education. And some people you'll see big kinematic changes at the hips, in others you won't. And it's not repeatable. You can't turn around and say, right, you're going to do this, and this is what we're going to see. Life would get far too boring, in my opinion, if that did happen. And then it's then sort of speaking about muscles functioning in different ways depending on what stage of the gait cycle they're at, and it gets really, really interesting. So yes, learn, as Emma said, you need that baseline of understanding the gross anatomy. So go get your Grays, or actually the best textbook for anatomy, I feel, is the old McMinn's one. They don't, if you can find one, and that's basically just pro sections of the foot. And I've got 2 or 3, because every time one comes up, I'm like, yes, these are just like gold dust. I love these. And then even things like APSOs, like 3D4 Medical, they've even got like AR versions now. You can put a human foot, project it into your living room. And I was just thinking, actually, when I was a student, how great was that? But then actually before the pandemic, about 50,000 years ago, it feels about now, me and Emma used to run
Oh, we lost Nick for a while.
Oh, he's gone. I'll finish his sentence because I know what he was about to say.
I think it's because he said bugger. I think that was just a YouTube story about.
He's just been banned from the internet.
Yeah, what was he going to say?
He was about to say we ran a cadaver anatomy course. And so we would get into the Centre for Anatomical Sciences at the University of Southampton Hospital, General Hospital, and do a morning of just like revealing all of the intricacies of the foot and ankle. We ran it for podiatrists, and so we had a strong engagement on foot and ankle. And then we would in the afternoon go off and look at the function, and so we would look at models of function, and with my PhD interest in the influence of time during running on how the foot functions across a race or across a prolonged run. We would start to look at the models of function and how that can move you on to the next level of problem solving in a clinic. So not only do you know what is hurting, but you know when it's hurting and why it's hurting, and how the mechanical scenario, the mechanical environment can be reversed to take the load off that structure and then return it back to normal function.
Talking of normal function, welcome back, Nick. Thanks for joining us again. Having said that, though, your microphone and there's a bit of a noise. I think you should go out and come back in again.
Yeah, I'll leave and I'll come back.
Yeah, I'll help him out. There you go. That's really interesting. I mean, I've got this thing about death going on. I would not be very good at a cadaver kind of. I'm just not very good at that. but I would really love to see somebody who's kind of more evidence informed, still doing a cadaver workshop, and then. Because that could be used. I mean, the pendulum could swing very much easily too far the other way, because what you see, first of all, in a cadaver of dead tissue, we already know for the whole kind of the fuzz speech and Gil Headley and all of that, a lot of that was negated because he was working with a dead body, which didn't help. Yeah. But it must be really interesting to show that and then reflect on it and update it a little bit. Do you find that something you manage to do? Like in the afternoon when you're going through function, is there kind of contradictions where you'd expect this to happen, but look, is that kind of what comes across? Yeah. So when you start looking at cadaver science, the troubles that we find are that cadavers are often preserved in chemicals that change the properties of the tissues. So what might be really elastic in a living person becomes quite stiff in a preserved cadaver. So the preferable science, if you're going to do cadaver science, is to use fresh frozen specimens. Or there is another type of preservation. The name always escapes me. I can never remember what it's called. That essentially maintains the characteristics of the tissues, so that it is more lifelike. Should you load the cadaver and move it through, for example, a step using a mechanical rig, and that creates a little bit more of a lifelike set of data. But yeah, of course, there is no substitute for it. And a few years ago, you might have come across a group from Sweden and Salford and various places that all got together and went off to Sweden to stick some bone pins in to find out how the foot really moves. And they anaesthetized, used local anesthetic, anaesthetized the nerves to their feet, drilled cortical bone pins in like madmen. They were all men, I hate that. And walked up and down a walkway, and they had, I think, 10 feet they were able to get data on. And that was fantastic. It was groundbreaking, and it was novel, and some of the best the nearest to lifelike science you're going to get on real bone movement without it being a dead body. But of course, they knocked out the nervous system, and that was one of the biggest criticisms of the study, of course. But anyone sitting there criticizing, I'd love to know how they're going to do better. So we're always left with proxies, and when you start looking at movement science, you're pretty much left with stuff stuck to the skin, and we all know skin moves. So all I would say is, with finite element modeling, with bone pin studies, with regular markered and markerless data of cadavers or living people, they're all helpful. They help to build the picture. And we shouldn't rely really on anything too much, because none of it really relates to the pathological person anyway. And every pathological person is different anyway. So they're helpful, but not the answer.
But that was really helpful, that paper, to really debunk the myth that the midfoot doesn't lock.
Oh, it was awesome.
Yeah, it's such a great paper. And yeah, I think the reason it had to be done is you'd never get ethical approval for that in the UK, would you? That's
what I was thinking. Yeah, good old Sweden. Yeah, you can stick pins in yourself if you want to. Come on over. Crazy.
So
that was Landgren's paper.
Yeah. Going back to the anatomy and the sort of pro-section days that me and Emma run, I think that links nicely into sort of then the anatomical variation. Is that Even if you go and do a quick Google Scholar search or PubMed search about lower limb variation, there are hundreds of papers where people document different variations within the lower limb. So, for example, adductor lucis brevis, there are some people saying, some papers showing that instead of 2 heads, it's actually got 3 heads. There are, when I was in one of the dissection labs, actually the medial structure along the medial ankle, sort of Tom, Dick and Harry, actually didn't run in Tom, Dick and Harry. They ran differently. And there are some papers that show that actually... Really? There are some papers that show that flexor digitorum longus and flexor lucis longus actually have many fibrous connections between them. And that doesn't happen in everyone. It happens in some people. And then you can then even get in discussion about accessory bones, accessory muscles in the foot. How can an accessory navicular affect pain and function? And this is where anatomy gets so fun. But again, anatomy isn't always 100% reliable because we're all a bit different at times, and it's great fun, but it's something that you've always got to appreciate and I think learn and try and strive to be better at. And one of the ways that I like is when we have students to try and help with them surface anatomy is we get muscle stimulators and we put it on different parts of the lower limb and just try and say, well, actually, you think you know where something is. Well, let's put a small electrical current through it and see what moves and what doesn't move. Or another great exercise is trying to draw the bones on the foot. And it sounds really, really simple, but actually it's really, really difficult. People don't realize how long the metatarsals are, how big and long, how wide the navicular is. And then when you then start doing that, you then really get a really fine appreciation for anatomy and how complex it is and how important it is. And obviously, I'm going to be biased, and Emma will be, because we're both podiatrists, but I think sort of foot anatomy is most probably one of the most complex regions out there. Don't ask me about hands, because if you ever see me treating a hand, something's gone wrong, because I can't even name the anatomy in the hand. But I think the foot's incredibly complex.
I had a radiologist once wish me luck when I said I was going to pick up an ultrasound probe. Because it is every millimeter can make a difference in a foot. So yeah,
it's fascinating. I just wonder whether, and again, you guys don't see the kind of syllabi that are out there for probably the top 5 examining boards who are throwing out sports massage therapists and sports therapists. The syllabi is horrible. And if they just tweaked it a little bit and just mentioned anatomical variance just at the beginning, just to sow that seed, rather than producing these people who believe that symmetry and pain correlate perfectly and that's the goal and everyone's the same. And it's a shame. It's just, I don't know, there seems to be a lot of inability to change examining papers. It's probably just costs too much, or it's just a massive thing. It's just too large scale. It depends on, sadly, in our profession, it's about, and we always recommend this when we get people, where should I study? Where should I do level 5? I've been told I need to do level 5. And it's like, just go by the teacher. Don't go by the examining board, because if they're just delivering what the examining paper wants you to do, you're going to get a pretty dire, you'll pass the exam, but you're going to go to clinic and nothing's going to really help. So you really need time. Yeah.
When you're designing believe me, this is my life. Welcome to my life. When you're designing an exam, you can't base it on what might happen. You have to base it on what's likely to happen, because that'll be in the textbooks and that's what's likely to walk through the door in a clinic. There are always the zebras instead of the horses that come in, and there are always the weird and wonderful. And that's where you need your specialist to have that next level of expertise and anatomy knowledge and skills and all of that good stuff. But I would seek to have, most of a profession with a good baseline, like rather than trying to run before they can walk, if you'll excuse the pun. I would prefer that everyone knows roughly what's in there and roughly where it goes and what it crosses and what it does. And then from that point, they can build on it. Of course, we have the luxury. We've got, people say we just do the foot and ankle until they sit with their popcorn and listen to me and Nick talking for a couple of hours, and then they realize it's not just a foot at all. But you can see why when you invest in a part of the anatomy that is this complex and this specialized. I've been studying anatomy I started my studies in 1992, and I'm still in the anatomy lab seeing new things now. in 2022. So, 30 years later, here I am still seeing things slightly differently because I learn more and I go back and I see more. So, yeah, of course, I'm going to spot stuff in a clinic that someone else with a baseline knowledge won't see. And that's fine. That's why I'm here.
But that you can't teach experience, though, can you? So
no, but also it's that investment, the years of investment,
exactly.
isn't it, as well?
But it's also like any sort of course, and I say to students that come with us, going through a podiatry degree will get to a point where you are safe. The idea is you pass the exam and you are a safe practitioner. But actually, I'll turn around and say it's like driving your car. If you pass your test, you are a safe driver, but you actually really learn to drive after you pass your test. And this is the thing, is that actually just because everyone, and I was the same. When I graduated, I thought, right, that's it. I graduated. I know everything that I need to know. And every year that goes on past my graduation, I realize I know less and less and less and less and less. And it is just having that expectation of, okay, once you've passed something, whether it be level 5, 6 or 7, it doesn't matter. You still then, that's expert. You need to then keep pushing forward. You've been given the foundations, but now's the time to go and actually hone where you want to go and learn and progress further. That's what I would say, really.
Fantastic. Very well put. Excellent. I've just got to bring up Catherine's comment here because it's just lovely, and I love everything Catherine says. But Catherine, going back to the I have to say cadaver because my wife's from Wigan, so it's a cadaver, it's not a cadaver. That sounds too posh to me now, it's a cadaver. Anyway, yeah, she says, I'll be in the cadaver workshop again at Keele University in October with Mike Rice and moving therapy education. I seem to spend more, I seem to spend more time with dead people these days, but I do enjoy it. Classic, Catherine.
This is the answer back.
That's going to be a screenshot, definitely. There's a new something. I think that'd be nice in your Facebook profile. I see the dead. Yeah, lovely, Catherine. Thanks for sharing. We've got a question here from Nikki, if that's okay. Nikki Mansfield says, was it Nick that? What was it Nick just said about the bone pin study proving that something didn't lock during supination? Please could he repeat, explain?
So there was this theory that the midfoot used to lock, which then helped push us forward, and but we now know from the bone pin study that doesn't happen. The midfoot doesn't lock, and we thought that for years and years and years and years. But then the bone pin study sort of blew our mind and realized, oh, actually, we've been thinking this for the last 20 years, but actually what we've learned in the last 20 years in one study we just proved was basically inaccurate. So,
and part of that is about terminology, isn't it, Nick? Because we inherited, you might have heard of Ruta Ryan and Weed, like Rutian biomechanics in the foot, which was all based around an ideal design of a foot, if you like, a rectus foot, straight foot. The rear foot's like this, the forefoot's like this, and they just wander around on the ground. And if the forefoot is twisted up one way or the other, or the heel is, that's going to cause compensations and then pain. So it was a lovely theory, and we all we all got behind that for a long time because it was all we had. And of course, like all these things, sometimes they get better in spite of what you do, not because of what you do. So we didn't have much cause to question it. But there were obviously the patients that didn't get better with that, and also the ones I couldn't explain at all. So, the Salford group did a lot of work on this, Chris Nestor's group in particular. And basically, through the bone pin studies and other work as well, they've just changed the language. And we don't use language in the same way, like locking and unlocking and forefoot varices and things like that in the same way. Not functionally in the same way. It is absolutely true that the foot stiffens during the loading phase of walking and running. And that happens because there's, some structures that are across the bottom of the foot. And when you load down on the foot, it creates tension in those structures that span across the bottom. And that helps then to compress the bones together. So they do stiffen up, especially the lateral column. And that helps the peroneus longus to pull off the cuboid, for example. But it's not by the mechanism that we thought it was, as Nick said, and it's just changing that language slightly changes how we perceive movement and what we assess for.
Yeah, I'm a big fan of when you said lock, I was thinking, well, how much is this just a change of the word? Because lock's pretty definite, isn't it? you know, and you could go to subtalar joint, lots of joints where just because someone thinks it's locked, that's it, they think they're incapacitated. I'm never going to move again, this is why I'm in pain. I'm not going to think of any other factors, it's just because the bone's locking. So it's a pretty dodgy word. We've talked about that quite a lot, and some people are going, oh, it's just a word, it's not so important. But I think the first step to understanding variety and stuff is caring about the words you use, because it helps you with so many things. And you can go over the top, but I think it really helps questioning words and getting a bit geeky about it. It doesn't come natural to everybody. I think to us three it does, but some therapists are like, oh, what's the difference? But it does matter.
Well, I can give you a really lovely example of where it would make a difference. When you're working with a root paradigm, for example, which a lot of people still do, and like I say, they will be getting people better almost by accident, because a lot of the time we do. But what they'll be aiming for, if they are subscribed fully to the paradigm of root, they'll be aiming to avoid the compensations caused by those rotational deviations that have been identified through, you know, some manual testing, static manual testing, and the inference that will affect movement, which again has been proven not to be the case. But regardless, they'll be aiming to achieve something through the root model that looks like an outcome that would be, you know, a good routian outcome. But what we know now, for example, I was going to talk about this, in fact, when it comes to what the work of the intrinsics is. So the intrinsic muscles act to stiffen the foot. So you need a stiff foot. You can't push off a wobbly foot. It's 28 bones. I describe it to the students I work with like a bag of Revels. You know, you can't push off a bag of Revels. You need a crunchy bar. It needs to be nice and stiff. So you need stuff to stiffen it up. The bones are obviously stiff, but there's lots of them. So you've got fascia and ligaments and capsules and muscles in there, and tendons as well, that help to achieve that stiffening function. And then, of course, the more vertical the foot becomes during a push-off phase, it stacks like cotton reels, and that adds to its geometric stiffness as well. So, you know, what we know is that when you allow the arch to compress, the foot will stiffen and then create energy, elastic energy that it can return on the sort of the release of the foot from the floor. And if we start to impact that, for example, if we put an orthosis into someone's shoe that supported their arch, there are some people that do need arch support. Okay, so there are some people who have pain in their midfoot. They need to have that arch stopped from moving to avoid pain. I'm not anti-arch supports. Again, it's another one that gets demonized. But as a rule of thumb, generally speaking, the foot that doesn't have arthritis and does function fairly, you know, optimally, it works with that deformation, that compression of the arch. It likes it because then it can use that energy to return. So if you put something in there to stop it deforming, it can't do its job. It can't actually deform and then spring back. So what we know is that if you reduce arch deformation in running by about 10%, you lose about 70% of the energy return. So you might be robbing Peter to pay Paul. And that might be okay. It might be a therapeutic decision that you decide to do, but you understand the offset. But don't do it blindly, because that person may suddenly find that they're now using a muscle to try and stiffen the foot because they can't use that nice compression mechanism that they were using before. And so arguably orthoses actually act as a bit of a gym in that respect, because you're forced then to input muscle energy to stiffen the foot, where before the foot would do it more naturally. So it's a complex picture, and shoes arguably do the same. If you introduce viscoelastic midsole, for example, you're introducing another spring into the foot that then it decreases its stiffness, and so then the foot has to arguably work harder. So it's always a trade-off, and that understanding about mechanics and energetics as well as anatomy can be the difference between getting someone better and not getting someone better.
Just going back to the anatomy bit, just something completely off track, and you said 28 bones in the foot. A lot of people will say 26, and one of my family members sort of said the other day 26 bones in the foot, and I had this nervous twitch. And my 2.5-year-old piped up and sort of said, "Daddy, what about the sesamoids?" and I'm like, this shows that I really need to get out more. That 2.5-year-old knows, don't forget the sesamoids. Like,
yeah, you're creating a monster. Yeah.
So yeah, sorry.
Scary.
Completely.
I'll get her on my course.
Yeah, exactly.
2 years old, sesamoids. Brilliant.
So,
That yeah, no, it's fascinating, and it's again, you explain it in a way, and this is where therapists need to be educators and not just learn how to do things with their hands. They need to be able to explain these things, because students, I mean, that's your profession, that's what you do, obviously it's why you are where you are, but therapists need to be able to explain these things in a way that the client or patient will understand as well, and start doing what you ask them to do at home, and they'll get it, won't they, and stop depending on other ideas they've got. But
and you talk about that, and that's, people sort of say to me, okay, why do you use 3D gait analysis in clinic? Because there are still so many variables. I can't measure muscle forces with it, and we know that kinematics, the changes of angles, doesn't always correlate to pain or function. But actually, for me, when speaking to patients, the biggest use of actually using the 3D gait in clinic is actually an educational tool to patients to help them understand what's going on, why we try and do the treatment modality X, Y, and Z. And you are educating that patient. And I completely agree with you that, yes, we get educated while we're training, but then we also need to be able to then educate our patient, and then also demedicalize it and put it in a language that is sort of, get rid of the medical jargon, just nice and simple for patients, diagrams and pictures and what, hence why in our clinic you'll see, I'm in my home office at the moment, and in my corner there is a whiteboard, and in all our clinic rooms there are whiteboards, because that's what we use to help break down stuff for patients. And yeah, it is, that education bit is so important. Because I have a big belief, if you don't do that, you don't get what I call the emotional buy-in from patients. If you don't get that emotional buy-in, they're never going to commit to a treatment plan. You don't get the commitment, you're not going to get the results. But then that all comes down to, as Emma said at the beginning, that initial consultation, that's your window. You've got that one chance to sort of do it right. So that's where that whole initial consultation is so important. And people often will ask me and Emma about what's the perfect foot examination look like, and I'm like, it doesn't. But actually, if you come to see either of us for an initial consultation and say it's 45 minutes long, I can guarantee a good 35 minutes is actually having a chat. Actually, the hands-on, having a wiggle with a foot is most probably 5-10 minutes. And actually, sometimes you don't even need that, but the patient likes that. And I think this is where actually the pandemic has been helpful, because especially musculoskeletal therapy, virtual video consultations, you can't do your hands-on bit. So you have to really hone in on your history taking and your communication skills and whatnot.
So much there, Nick. And yourself, Emma. No, it's amazing. I'm just thinking, guys, you're gonna have to watch this back and pause it, because there's just so much information coming out there which is so relevant. I was gonna pick up on so many things now, you've thrown it out of my head, but I think I was just thinking as you were talking that one of the things that soft tissue therapists are often scared of is, yeah, you need to tweak a few things. Yeah, you need to understand maybe the psychosocial factors and make knowledge, but that doesn't mean you have to stop doing the traditional static assessment you did before, because that's a wonderful opportunity whilst you are checking whether you can fit 2 fingers under one medial arch and the other. Okay, so you're not going to conclude that's why your pain is, but whilst you're doing that, the patient's buying in, they like it, they feel looked after, and you're maybe looking at their reaction by something you're saying and not necessarily what their medial arch is doing. So it always seems to be the message from guys like yourselves is you don't have to throw everything out. You're going to tweak it a little bit, keep doing what you do. The skills you've got are fantastic. You haven't wasted any money at all. Well, it depends who you study with, but a lot of it is still very relevant, because you're going to keep doing it. It's just what you do with the information and what you're kind of focusing on when you've got it all together.
The problem is that we subscribe to pets. We have pet therapies, pet tests, pet workflows. We get into ruts and we like habits. They get us through our busy day in the clinic as well. So I don't blame people for it. I've been very guilty of it myself. But I would always come back to, what is the question you're asking and how are you going to answer that question? And if you want to know whether navicular is X millimeters away from the ground when standing, then measure it standing. If you want to work out how much it drops during running, get a tool that will measure it running. Because we know that there are some tests. So navicular height is actually one of them that will predict with some level of accuracy and reliability the lowest point of the navicular in running gait. But the foot posture index is neither a use nor ornament when it comes to that. So it all comes down to the question you're asking and the sensitivity, the reliability, the sensitivity, specificity of the test. So a little bit of science in there to understand when a test is going to tell you the truth or going to tell you a lie. And that will come down to the complexity of the test, whether it's able to measure the thing inside or a proxy for the thing inside. I know it's getting a little bit sciencey, and I don't want to get too much into that, but this is the reason why I find working with clinicians, coming from that 0 point right the way through to advanced practice, that the awakening that happens somewhere along the way is that they begin to take control and command of their tools. And that means understanding what it is they're asking and what it is they're using to answer that question. And suddenly you realize you're using a whole load of crocs for tests. But that said, one test can be really great at answering one question, but really rubbish at answering another. So you need to go back to the literature and ask yourself what it was designed for, and are you still using it for that?
It almost feels like we need to get on like Would I Lie to You and do a panel about another.
It's a great idea, actually. I can think of a few other people to vote along. Yeah. Becky Carroll here. Becky, I mean, we've kind of mentioned, we haven't said the word yet because it seems like no one wants to say it, but overpronation. Actually, Nick said a pronated foot. But yeah, this is something, I mean, it's a word which I think has been demonized, but again, it opens the door to, well, I mean, Nick, I'm sure it's the same for you. Like whoever was working with gait 10 years ago, that was the way you suggested shoes, wasn't it? You'd look at the subtalar joints, see if they were neutral or not when you stopped the camera and used your eyes, or maybe a little measurement. And now that's all gone out the window, kind of thing, really, what it has in terms of using that for gait analysis. But it's still a really nice way of gently showing somebody how something does change. Becky here has asked, like overpronation, let's bring it up on the screen, Becky. Great question, by the way, Becky. Overpronation, it seems to be wrongly demonized by many, even still despite current research. However, when is overpronation deemed an issue in podiatry? I suppose first you've got to define overpronation.
So firstly, I'll answer. When we talk about changing the language I use in clinic, when I first graduated, I used to keep, and I still do, is keep a log of interesting patients and then write down, obviously take out all the personal identifiable data and whatnot, and create a book on writing interesting cases. And I was looking back on that about a year ago, and there was times where I put the diagnosis as overpronation. And if I'd done that now, I would. Yeah.
It's a safe space, Nick. You're fine.
Yeah, I know. It's
fine. That's the best you had at the time.
Yeah,
why not?
Exactly. That's the best I knew. And it's the issue I have with the term is that we don't know what normal is. So if we don't know what the normative values are, how can you over or underuse something? And it does always, a lot of the time, get a lot of the blame when it comes to injuries. Like people they see a flat foot and they say, oh, this is an overpronated foot. You need to get foot orthoses because otherwise you are going to get problems X, Y, and Z. There are some of the best marathon runners over the last 30 years have feet as flat as a pancake that actually can still run a sub 2 hour 10 marathon. And no one's going to change those because you'd be silly to do that. I think it comes back into trying to link it and understand, is it related to the pathology that they're presenting with or not? So just because you see a foot that is flat, but they may be presenting with something that's got actually no correlation to a flat foot. So you're like, you got a flat foot, so you got a flat foot, but it's not actually related to why you're coming in. So it goes back to that history and examination and going back, is it relevant to that problem? So when is it an issue? To me, it's a foot pronation and is only issue when I think it could be aggravating someone. So if someone comes in with a tibialis posterior tendon dysfunction and you're watching them walk and you think, well, this foot looks like it could be pronating at a high velocity so very quickly. Well, actually, that could be a contributing factor towards why it's aggravating symptoms. We're not saying it's caused the symptoms, but we're saying it may not be helping. So it's going back to actually relating it back to that patient, and we can't determine what is over, what is under. And Ian Griffiths, I think, is a guest next week.
Next week, yeah.
Actually,
I was gonna save that for a little bombshell at the end, but that's fine.
Sorry.
That's right. Don't worry, Nick. It's okay. You go
Sorry.
We now know that next week's Ian, and we know the week after's James. So yeah, keep going. It's fine.
There we go. I don't know any others, so I can't spoil any others. He always used to do a nice diagram about using a lift, for example. I think at the starting position, so say if a really pronated foot type is a +3 on that lift position, but actually if you started in +2 and you ended up in +3, you've only moved one level. But actually if you started on -3 and you ended up on 0, so what looks like to be a neutral foot type in inverted commas, as it were, your foot's actually moved more, but people have assumed the overpronated foot type is the first one, but even though it's moved less. So I think you need to look at the bigger picture. You need to look at also the volume of motion from start to finish, but then also going back to, is it actually relevant to that problem someone's coming in with?
I mean, honestly, this is one that if you put a hand grenade in a bunch of podiatrists, this is going to set us off something chronic. So to add to Nick's answer there, which I totally agree with in terms of, is it a problem? That is the very first question. But then I would say, what is the problem? What even is pronation anyway? And if we're talking about heel eversion, then fine, let's talk about heel eversion. Let's not call it pronation. Pronation arguably is a triaxial movement, a multi-segmental triaxial movement in weight-bearing response of the foot. Well, gosh, who wants to talk about
call it that?
Let's call it that. It's so
rolls
easy
off the tongue nicely, doesn't it?
Yeah, but actually what we see is, planal dominance in people. So some people will pronate just mostly in the sagittal plane, their arch just drops. Other people do a lot of frontal plane, so rotation, and other people sag in the middle, to kind of sag their foot inwards in the transverse plane. So there really is no way of capturing what you mean when you're talking about pronation unless you define it. So that's the first thing. What is it? And secondly, is it too much? So are we working within an envelope of tolerance for that individual or not? It's not about a shape unless it's changed. If it's changed recently, and especially unilaterally, it's a problem. So monitoring foot shape change in one of those directions, be it collapse, sag, or rotation, I would definitely send that off for some sort of deeper investigation. And of course, if it's painful, exactly as Nick said. And we have got a question about pain. I don't know if we've got time to talk about it.
Definitely, because it'll bring Claire in nicely. It links in nicely, doesn't it? Claire Walker, if you're listening to the podcast, you can't see this, but Claire Walker's comments, because she's joined us live. Claire says, I'm really interested in the pain science of the foot, briefly mentioned.
Okay, well, I will just quickly dip in on that one, because I was just having a think as I was reading it. One of the things I would say to podiatry students and podiatrists on CPD days is work out if it's mechanical pain. If it's mechanical pain, like, bag them, they're yours. That's the one that podiatry can do, because we work with mechanical therapies a lot. If it's psychosomatic pain, if it's complex pain, if it's organic pain that is something to do with the dysfunction of the neurological system itself, you're probably not going to get very far with a podiatry intervention. And I wouldn't wish to step on the toes of sports therapists to understand exactly what it is that you are able to influence. But in terms of my own profession, I would say that, we often see multiple components of pain as well. So some of it will be inflammatory, some of it will be mechanical. And when you just literally change the stresses and strains, I can reduce their pain down to 0 sometimes, if we're going to use numbers. But if it's inflammatory, then I know to expect a different response over time, and it'll possibly need a systemic approach as well. Neurological pain, again, very different. So it's all about understanding where the pain is coming from. What is the type of the pain? Is it multiple types of pain as well combined? And if it takes ages to get there, it's probably going to take ages to go away, unless it's mechanical.
Again, so much there.
I think that all then comes back to then knowing when to refer on.
Yeah.
There'll be stuff that present to us as podiatrists in the clinic that will then turn around and say, no, you need to go to rheumatology, or we need to refer you to the pain team, or one of our graduate sports rehabilitators, he has done some extra training in sort of biopsychosocial pain management approaches and speaking to people about the science behind pain. So we'll turn around and say, look, in the clinic, I'm not the person, but actually another one of our team members is better suited to try and help you, because that's where his skills lie, not my skills. So it's trying to work, as Emma says, that source of pain. And then also, Becky, yeah, don't worry about the hand grenade at all. We could speak most of another hour and a half on that subject.
I know, that's why I say
Becky, I loved your grenade. Don't apologise.
Yeah.
Becky, yeah, fantastic. Any Becky grenades, very welcome on the show. We have reached 9 o'clock actually, so it's we could go on for ages, but I'm really thankful to you guys. Just, I don't want to forget, because we talked about this a bit before, Nick, it sounds very exciting what you've got going on in clinic. You've got covering exactly that assessment, going through the assessment. You've got 12 people, is it face-to-face in the clinic?
Yeah, so we haven't launched it yet. So I'm launching it
Good.
end
I'm
of this week.
surprised now as well.
Fantastic. So it's sort of, we're equal on the surprises now. We are planning to launch a CPD day, which is going to be held in our clinic in Romsey for 12 people, and it is going to be about telling the patient story, and it's going through about a musculoskeletal assessment, but it's not the conventional of, okay, how do you assess a joint, how does a joint move? It's more about going through about communicating with the patient, understanding why they're coming to see us, the intervention, and then the intervention was going to be about then speaking about the rehabilitation process and taking people through that, because there'll be different barriers to people where they have access to gyms, previous experiences, you name it. And then in the final bit is then talking about, okay, what happens next? How do you follow that patient up? How do you then try and set them up to succeed in the future? Because as a private clinic, we aim to discharge every patient we see to a point where we'll then even monitor our patients 6, 12 and 18 months down the line to check that they're doing okay. And a lot of the time we'll find our patients are actually doubling the amount of sport and exercise that they are doing 18 months down the line. So we're at the point where you're like, thanks guys at NK Active, yeah, we don't need you anymore, I'm off. And that's what we want. So it's now saying, okay, we decided to put a course together to speak through how we do that journey with a focus on rehab.
Sounds great. I mean, based on what we've heard, I'm knowing that you guys are very much on the same page, but willing to kind of chew stuff over and disagree and have fun doing so. It sounds like it's going to be an amazing course. But again, it's kind of like to get the most from that, it's kind of important, like we said, that you've gone through the fundamental anatomy, that you've gone through maybe a few things which are gross generalizations and painted black and white. So that's how we learn, isn't it? You couldn't have a student who starts off with, well, it could be this, but sometimes it's this. No one would be able to learn that way. You have to learn black and white and then kind of open it up a little bit, don't you? So sounds brilliant. Really
there'll be
Nick.
Lots of pre-reading but if you don't do the pre-reading, the day won't make sense.
Yeah, I'm sure. As created by your 2-year-old, I imagine.
Yeah, exactly.
To get this his feet. System always steady, brilliant. And Emma, what have you got coming up? Because you're heavily involved in education in Southampton. What's exciting happening there?
Well, I was just sharing with you, Matt, just before we kicked off about the people I work with at Southampton. Yes, we're a motley crew of podiatrists, but also other people as well. So I work with biomechanists and sports scientists and ex-sport therapists as well, who've gone on into a research pathway, either directly into sort of a more biomechanics-based research portfolio, or gone on to study podiatry or physiotherapy or occupational therapy, to sort of join a more, I don't know, a population that is perhaps a bit more pathological. I should imagine you guys work more with healthy people, keeping them at that end of health and wellness and performance, and we perhaps work with a little bit more of the pathological end. But, you know, rowers get diabetes and runners get rheumatoid arthritis and all sorts of stuff. So, you know, if anybody's interested in combining and dual training or seeking out a research career or something, I'd be really open to a chat about that.
Fantastic. And the best, are you quite active on social media? If you want to follow your thoughts, is there a particular?
Yeah, by all means. I'm at Emma Cowley, PhD.
Okay, on any particular platform or?
Oh,
you're on Instagram? All of them.
The only one I'm not really doing at the moment is TikTok. I haven't got the dance, I haven't got the moves.
Still, I'm sure you're working on it. I'm sure. That's fantastic. Yeah. And Nick, you're NK Active in most places?
Yeah, NK Active Clinic on most places, and then also NK Sports Pod on Twitter. But fantastic. Yeah, we are on. Well, actually, say we're on TikTok. We have a TikTok account, but I don't manage it. So it's and there's nothing of me dancing. Sorry.
No, well, yeah, past that a bit now, but there would have been
Doing a
one
shuffle,
day.
that could be a thing.
Listen, guys, it's been really interesting. There really is so much information there to pick apart. So I'm hoping that if people do have questions and listen to it again, then the joy of YouTube is it kind of sticks around more, doesn't get disappear in Facebook. So this will always be here in YouTube now. It will come up in Google search results, and the more of you who leave comments and ask questions and come back, then the more it will appear in search results. So do use this now. If you've got any questions about the foot and ankle, then stick them in the comments, and I will forward them to Nick and Emma, and who knows, you might even get one to come and give you a result in person, a little reply on YouTube. So keep it going. I'm going to sign these people out now. If you guys can just stick around for 2 minutes more so I can thank you personally. So don't click any buttons or anything yet. So everyone in the live lounge, thanks for joining us. Really appreciate it. Thanks for some great questions. And thanks for the hand grenades, Becky. We will be back next week. And it gives me great pleasure to announce now, because you don't know, that we have got the fantastic Ian Griffiths in person, along with Maddie Tate, who together are going to be, I'm looking forward to this. We were trying to think of something where sports, particularly sports therapists and sports massage therapists ears will pick up. And the episode is going to be called plantar fasciitis, ... or is it? Look at that for a hook. Isn't that great? So yeah, we're going to be looking at the relationship of the foot and ankle with relation to plantar fasciitis or plantar fasciopathy, if you want to kind of like use that term. So it's going to be a whole hour on that with, again, two hugely great educators and people in the game. So looking forward to that. Just come along to YouTube on Tuesday, same time, 8 o'clock, and that's where we'll be doing it. But for now, on behalf of Nick Knight and Dr Emma Cowley, who I thank once again for giving up the time, thanks for joining us, and yeah, take care of each other. We'll see you next week, hopefully.
Thank you for having us.
Yeah, thanks for having us.
Bye bye.